going to demonstrate abdominal examination. So, Yevin, is it okay examine me? We will start with a general examination first. We are looking for, first thing is a clubbing. So then you have to look for the farmer erythema. Right, so that is indicator of CLCD. And then sometime you have to feel the palm to look for the diffuse contractures. Sometimes you can see obviously diffuse contractures, but otherwise you have to feel it. So you have to ask the patient to lift and look for the whether there is a flap. That is called the flapping tremor. If it is there, that indicates the underlying hepatic encephalopathy. So you have to look for the conjunctival fellow. Can you look down for me? Right. And look for the icterus. You have to come behind and I'm going to palpate the lymph node, right? So this is how you play the lymph node and go back and come to the anterior triangle and then the posterior triangle and then look for the supraclavicular implant. At the same time, you feel from the sacral area, you press and see whether there is any sacral edema. Tap for the loin, also loin area to see whether there is any renal tech. So you have to peel and press whether there is ankle edema. So you have to press the 1 minute over the ankle. So abdominal examination, usually patient should be flat. Right? Otherwise, when the abdominal muscle will be contracted, and then in the top-up position, you can't examine the abdomen. Ideally, we have to expose from the sternum to the mid-thigh. That is how textbook is described. But we at least expose to the up to the symphysis pubis level. Usually, to do the inspection, you have to lie kept down and keep your eye and ask the patient to take breath in and out. You have to see whether there is abdominal movement, whether it's a symmetrical movement or asymmetrical movement. And then whether there is any abdominal distension, you have to see whether there is asymmetrical or the symmetrical abdominal distension. And then you have to look for whether there is any scars. So how to start a palpation? First, you have to ask from the patient whether there is any painful area of the abdomen, right? And then you have to avoid that area, right? The palpation usually starts from the RIF, right iliac fossa, and then first it's go circular manner, and then the first is a superficial palpation. So you start here and go like this, right? And then here, and then come to the LIF, and then come to the suprapubic area. Deep palpation, right? In deep palpation, gain the same method. Always when you are palpating, you have to look at the patient face, because if there is any pain, patient will express his underlying pain by the facial appearance, right? So if patient is in pain, you have to ask again and reconfirm, and if it is a pain, you have to stop it. Under palpation, you have to palpate very important three structures. What are the three structures we are going to palpate? Liver, spleen, and kidney. How to palpate the liver? How to palpate the liver? So you start when the liver is enlarged, it descends downward this way. So you start to palpate the liver, right, from here, right? So you keep your fingertip. That's the most sensitive part of your finger. Right? You see the fingertip, right, here, and asking him to take deep breath in and out. While taking deep breath in and out, you should move your hand gradually up. Right. At some point, you can feel the lower border of the liver. If you feel the lower border of the liver, so what you have to do, you can do two things. One thing is you have to mark the side, and you take a tape, and from you have to measure from the right costal margin to that edge in centimeters. Right. Other thing is you can count with the finger breadth. Right? You have to say that, okay, one finger breadth, two finger breadth, liver is enlarged in the right from the right costal margin, two finger breadth, or you can say the 2 centimeters or 3 centimeters. over the liver, you have to look for the consistency, whether soft, hard, and when over the liver, you have to feel it surface, smooth surface or nodular surface. Then you have to look for the upper border of the liver to differentiate whether this is a real enlarged liver or a push liver. How to identify the upper border? So you percuss from above downward. Here, resonance, and now it is dull. Now it is dull, so that is the upper border. Then you have to percuss from downward. Say suppose that if you get a dullness area here, then you have to mark this side and mark this side and measure this length by using a measuring tape. That's called liver span. Spleen, it is situated in the left side of the abdomen. When the spleen is enlarged, this direction. This is called inferomedially. You have to start ideally RIF for some. So you start here, gradually go up, right? Ask the patient to breathe in, right? From here, and you have to support the back by using your left hand and ask to take the deep breath in and out. So then even this position I can't feel, right? So then the spleen is not palpable, right? Where do you start spleen percussion? 1, 2, right? So his spleen is not enlarged. But if you get the enlarged spleen, you have to see you have to measure it from the left subcostal margin by using a measuring tape. You have to mention that whether it is a mild, moderate, or massive, right? Massive spleen. Massive spleen usually it crosses the midline and it comes here. These are usually ballatable, kidney ballotment. So you have to push your left hand, right, from the lumbar region or the loin area, and by pressing here, right, you move this left hand up, right, like this. See whether you can feel something and hit on your fingers. That is called ballotment, right? Palatable. There is a huge enlarged kidney. Obviously, without any obvious thing, you can feel it, but this is the ballotment. And then you have to demonstrate from the other side also. Keep your left hand on the loin area and push up while feeling from from your right hand. Then if it is enlarged, you will feel. Say suppose in the right side there is no problem. If there is a ballotable mass, you can say confidently say, okay, this is a kidney, right? In the left side, if you get a ballotable mass, then you have a question whether this is a enlarged spleen or whether this is an enlarged kidney. Four maneuvers to differentiate enlarged kidney from enlarged liver. First thing is, if you can feel the anterior notch, that is spleen, but in the enlarged kidney, you can't feel such a notch. Second thing, the kidneys are ballot, right? It's a ballotable thing, but the spleen is not ballotable. And then the third one is, and when you percuss, right? When you are percussing here, the kidney is a retroperitoneal lobe, right? Your transverse colon, you know that this is a cecum here, this ascending colon, transverse colon goes like this, and then the descending colon, sigmoid colon, and then the rectum and the anus, right? So when the transverse colon lie over the kidney, right? Lie over the kidney, when the kidney is enlarged, the transverse colon also push up, right? So then there will be a, when you are percussing, there will be a hyporesonant area when you are percussing over the transverse colon, right? So you percuss here, here, and then you get the hyperresonant band, right? So that is you will get in the enlarged kidney. Then the direction is the most important. When the spleen is involved, enlarged, it direct medially and inferior. And when the kidney is enlarged, it descends straight away inferior. So that is how you should differentiate spleen, enlarged spleen from the enlarged kidney. So how to percuss for the pre-fluid? So we start from the midline, right? We start from the midline, either way or either way, right? and the same percussion principle, but abdominal percussions are soft percussion, right? The thoracic percussions are the hard percussion. You have to percuss little bit hard. You have to feel and listen. Feel and listen. You will feel it is resonant, 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 but when it is come, you will get a dull. If you get dullness, you do like this, and then the dull, and here dull, and this dull. You get a band of dullness. Horseshoe dullness is indicative of the moderate amount of side issue. There is a horseshoe dullness. You have to demonstrate the whole shifting dullness. What is shifting dullness? Right? You percuss, resonant, 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 and then you will get a dull. Right? By keeping your finger here, you ask the patient more towards your side. And then you have to focus again. Then you will see like all the fluid is gravitate down and you will see again resonant percussion. That is we call shifting dullness. If there is a gross ascites, abdomen is hugely enlarged. So what you have to do, you have to perform a fluid thrill, right? How do you perform a fluid thrill? Right? You need another person. If there your assistant is there, you can ask the patient to keep the assistant hand on the middle of the abdomen, like this, right? Or else, if you don't have anybody, but make sure that you have to have a chaperone. Ask the patient, the chaperones keep the hand midline and the ulnar border touching the midline of the patient's midline, or else, right? I don't have anybody, right? So we'll ask get the patient set. So you keep the hand here and just tap here. Just tap. Then you will feel a thrill from this side. That is called fluid thrill. Then the auscultation. What are the things you have to look for? You put your stethoscope and we are looking for the few things. One thing is you keep over the liver, right? Liver, and see whether there is any bruit. Bruit means abnormal movement of the sound. You can hear like this, right? That is the liver bruit. That indicates increased vascularity, right? So it could be something inside the hemangioma kind of thing, or could be a underlying liver cancer. And then the second thing is you have to look for the renal fluid. Renal fluid is important when you are assessing a patient with young hypertension. Renal stenosis is a condition where you get a secondary hypertension. So where you have to auscultate along the renal artery, right? The renal artery, either side or the either side, right? Just lateral to the umbilicus. Keep your stethoscope and listen for a few seconds and whether you can hear a renal voice in either side. And the last thing is you should auscultate the bowel sounds. Bowel sound, auscultation of the bowel sounds important. It's very important in the condition where when there is a bowel obstruction. And sometimes some conditions you will not get the peristalsis. Okay? Bowel sound is absent, right? But it's called the bowel is not moving. We call that condition is a paralytic idea. When there is a mechanical obstruction, you can hear a high, exaggerated bowel sound. If you are suspecting any infection, say suppose the patient is having some urinary symptoms, fever, with chills and rigors, right? Again, you have to feel the suprapubic area, right? So this is important area. So you press it and you can see whether there is any the palpation of the suprapubic area that indicates the cystitis. So that makes the finish of the abdominal examination. Thank you very much. I appreciate your help. Huh?